Well, thank you. Thank you very much for joining us. Everyone, it is my honor tonight to introduce somebody that many of us have gotten, especially Chuck and I have gotten to know over the last I guess like 5 years now or so.
Probably crazy.
We've been sort of working and sharing patients together. So Dr. Garcia Santibanez is a expert of peripheral nerve. She's a neurologist by training, but she is sort of one of the world's best EMG and peripheral nerve sort of experts. Genuinely, when I came here and met her, I was blown away beyond anybody I'd met at some of my prior institutions, and have already learned a lot from her, share a lot of patients, and really honored to sort of call her friend and colleague. So Caroline, thank you very much for joining us. I think everybody's going to get a lot out of this. A lot of people I talked to are very excited to learn from you and listen to you, as they've already sort of learned a fair amount, sharing some of the patients with you.
Good. Thank you very much for that introduction. So yes, I'm one of the neuromuscular neurologists here at Emory, and we do, besides seeing a lot of neuromuscular disorders that that don't overlap with you, we see a lot of peripheral nerve injuries, or in general, like upper extremity neuropathies, as simple, because also simple for you guys, as simple as like carpal tunnel, ulnar neuropathies, but also complex plexopathies, injuries, immune plexopathies. And in the past few years, as Eric said, we've been collaborating a lot in patients that they evaluate in their clinic, and then they come to see us in the lab for nerve conduction studies. We get to do very interesting cases every time we get them from you guys. We do try to only do 1 or 2 per session because we don't have time to do too many complex studies, but I honestly love doing them. I'll do an arm 100 times more than a leg. I love doing upper extremities, like nerves in the upper extremities. I could just I just love it. And just like getting to, like, I remember like prior in fellowship, that's when I did a lot of like triceps 3 heads and deltoids 3 heads and like the trapezius every level. But then when I came to practice, like very few people asked for it, and we were like, we're not doing it. And then you guys came and started ordering all those more rare muscles, and we keep practicing and teach our fellows to do them too. And now one of our fellows trained by us for 2 years is joining Radius Neuromuscle. So maybe Nikki gets to work with him too. And he's also an expert in everyone. I don't think we get that many from Michael. I think we get more from Wagner and Zelensky, but every time we start, like, we have a Wagner special. That's how we call it. And everyone gets prepared because this person is going to get a lot of needles in their muscles.
The Nikki one, you should make sure you introduce Nikki to
I will. Andres,
to
I will, for sure. I think he's very excited. He's as excited as us doing electrical studies. So let me just get started. So this first, and Eric, you told me we have trainees, so I know this is basic for you and Michael and a lot of you guys, but I just wanted to just overview the different types of nerve injuries we have. Anytime, and I'm going to try to approach this talk on EMG on what I think an orthopedic doc should know. Like if you were trying to teach me what a neuromuscular doctor should know from the EMG, from orthopedics. And if it's too basic, then just bear with me. There's a few things that may sound a little bit basic, but I do think that for us in neuromuscle, I've had cardiologists come teach us amyloidosis, and hematologists come teach us protein disorders that cause neuropathies, and they're always worried that they're making it too simple, but I never found it simple. It's an area that I never got to learn really deeply. So I want to show you as much as I can in this hour on how we use nerve conduction studies in patients with peripheral nerve injuries. So as a reminder, you guys know this, we have different ways that we can classify nerve injuries. The most simplistic one is neuropraxia, axonotmesis, and neuromysis. And really for us in the lab, that's all we need because we cannot really differentiate the type of axonotmesis on the lab. For you for the surgical field, like that's important because it does allow you to prognosticate better, but these are things that you see when you're in there. But if you remember neuropraxia, that's the mildest degree of peripheral nerve injury. And usually in this type of nerve injury, you have injury of the motor and sensory fibers, but there is no Wallerian degeneration. So there's not going to be any dropout of axons distally that will cause abnormalities in your nerve conduction study. Very important to remember for when we are doing the nerve conduction studies. And usually it's thought to be due to conduction block from ischemia or focal demyelination. That's why the patient is weak. So maybe I compressed and my radial groove, and then I have a wrist drop. I have a wrist drop because there is focal conduction block across my spiral groove. And I'll tell you what conduction block means for us electrically. And that's actually due to focal ischemia or demyelination. And that has the best recovery. And it could be, depending on what needs to recover, usually focal ischemia recovers easier than demyelination. But we tell patients weeks to months to recover. And I'll be touching on this more in a bit, but if you see this picture here, this is the muscle that is weak, and we have the electrodes over that muscle. If we were to shock the nerve at S1 here and record under that muscle, we'll get a nice waveform. That is what I meant by there's good distal conduction. Then, at that time where that injury just happened, the patient just had a wrist drop, we can find an abnormality in our conduction study. So when we say like maybe it's too early for us to find things, it's more to pick up the axon loss, or because maybe the injury is not across an area that we can shock. So if you have an axillary neuropathy that is acute, I really don't have a good nerve conduction study, so I cannot document a normal response distally and then an absent response proximal. See, we can. But here, I can stimulate this radial nerve, for example. Let's say that my muscle that I am, let me just see if you guys can see me. Yeah, the muscle that I'm recording is my extensors, my extensor indicis proprius, for example. I can shock the nerve here and I get a good distal response. So I get that. But I stimulate the nerve again above the area that I think there's a compressor. So in this case, I'm compressing the nerve above the spiral groove and I get nothing. So I have found a conduction block on day one because the electrical response is not going through. But then why do we tell you, no, we need to wait a little bit to know what's happening? Because you'll see here when I talk to you about axon and misses and neuron misses, it's going to look the same. We get a response and we don't get anything here. But at day 10, and depending on the distance, depending on the literature you read, there's some that says 5, 7, 10. At day 10, for purposes of this picture, I do it again. I'm not expecting the person to recover. So we've told this patient that they're going to recover in weeks to months. But at day 10, I do the same study and I still get a good response distally and I get nothing proximally. So it tells me that the reason why things are not going through here is because of conduction block and not because there is. Okay, so go to axon and misses and neuron misses for the purpose of this picture, but axon and misses, remember here, you are going to, this is a typical one that you get with crush injuries or stretch injuries, motor vehicle accident, a fall, percussion injuries, if you get like a gunshot with it, that doesn't actually like go through the nerve. And in this one, the axon is damaged, the myelin sheets are damaged, but then what remains is intact is the surrounding stroma, all this connective tissue around the nerve that for us in axon and misses with sudden, that's as detailed as we get. But then depending on whether the endoneurium is disrupted versus the perineurium disrupted, the epineurium is always going to be intact. Depending on what part of that covering is affected, you get the different degrees. And the more coverings that you damage, the worse prognosis you have. But in someone with that complete axonomesis or neuromesis, so let's say that this person had a severe compression across the spiral groove because he was on the ground for 24 hours or he was being crushed by something. If I have the same wrist drop and I get the nerve conduction study that day, I'm not going to get anything proximally again. So I cannot tell you from an electrophysiologic standpoint any prognosis at day 1, but then at day 10, Wallerian degeneration has happened, and at day 10, I don't get any response. So that already tells me that axon damage has happened, and now the prognosis has changed. And we'll go into more detail on this in a bit. Not uncommonly, we get a mixed lesion. So a mixed lesion is one in which we get both weakness driven by conduction block because there's focal demyelination, focal ischemia, and some weakness driven by axon loss, but it's not purely axon loss or purely conduction block. In a patient with a mixed lesion at day 10, I still don't get that proximal response, but distally, I get a response that has been reduced in amplitude. So that takes me to, because one of the bigger questions is, when do we do these electrodiagnostic studies? When do we want to be ordering them? Sometimes you have to order it multiple times, and that's fine. It's as long as we have enough supporting evidence for the insurance to cover it. Sometimes when you guys want us to repeat studies, and sometimes we try to like push them a little bit because it's hard to sell into insurance. We're repeating it just because, not because there's a need. So if you document, for example, that a patient has worsened or hasn't improved as expected, that could be a reason for an EMG to get approved, for example. But let's say you have a person with a sudden onset of weakness and you know the mechanism of injury. You may need to really know that, you may really need to know the nature of the injury, and the lesion needs to be defined like right away, because you need to know whether you have to go in and approximate ends because of how the injury happened, or you need to go in and clean some things because you know the mechanism of the injury. So around 10 days, you can get a study. It's not going to be too early, especially if we know that we can stimulate across that segment. But approximately at the day 10, we can't tell you whether there is an axonomesis versus neuropraxia, for example, or neuromesis and axonomesis versus neuropraxia. So it could be helpful in those for 10 days. Then you'll probably repeat it again. You start planning surgery, and then maybe a few days go by. Let's repeat the EMG and see if there's denervation, because maybe at day 10, we don't have denervation yet, but we would have this drop of the this timing will be 4 weeks, because in 2 weeks, approximately, you start getting denervation, but it all depends on the degree of the injury. It depends on the length of the nerve. So a proximal nerve may denervate quickly. That's why in a radiculopathy, we get very, very easily and quickly denervation in your spinals. We're talking about a very short axon that needs to die back. In this case, the farther the nerve is, the longer it may take to develop denervation from the Wallerian degeneration. So 3 to 4 weeks post-injury is when you'll get the most information. But let's say that you actually found the injury of the nerve previously because you went in to do something else and you also saw the nerve and you already either tried to fix it, or you think that maybe it's not affected enough and you decided not to do any procedures for it. You can delay the EMG months later and get an EMG only study to see if there's any axon loss and any recovery. And us as neuromuscle docs, what do we look in at studies? So every time you send us a patient with a complaint of an upper extremity mononeuropathy or multiple mononeuropathies or applexopathy, we're going to be looking at our motor studies, specifically the CMAP. Yeah, there's a lot of things that we look for. We look for demyelination, axonal, but if we were to find a more diffuse demyelinating plexopathy, like that happens, you can have focal CIDP, an immune neuropathy that is only affecting the brachial plexus. Yeah, you guys want to know that, and we'll be discussing that case and giving your thoughts on that demyelination that we have. I've had with Eric patients that appear to have a brachial plexopathy, and I examine them and they actually have ALS, bibrachial ALS that happen in the upper extremities. So a lot of things are, the study could be completely take a huge turn and we find nothing of what you guys expected. But if we are going to find that mononeuropathy or multiple mononeuropathies or plexopathies, what we're going to be focusing in the motor studies is the CMAP, or the compound motor action potential, the SNAP, the sensory nerve action potential. Late responses, you'll see them less frequently helpful for you, and I'll tell you why. And then big thing, the needle EMG findings. So when we talk about a CMAP, and I'll show you tables later, every time you get a motor nerve conduction study, we give you distal latency, a measure of that velocity from distal latency means carpal tunnel, for example. We'll give you the size of the amplitude. We have normal values for each one of the amplitudes in the different nerves that we test. And then when we have done 2 measurements, we can give you velocity. So we cannot give you distal velocities, but when we have had a nerve that has 2 measurements that we can record, we can get conduction velocity. And the action potential is just this summated activity of the muscle fibers contracting after we stimulate multiple motor axons. And all those motor axons conduct that electricity, and the muscle contracts, and we get that motor unit. And these are examples of how that motor unit may look like. So this is I'm just putting an example of here how we measure the motor to the median nerve. So we are putting our recording electrode over the APB. We try to put it as close to where the end plate is, because that's where we get the largest amplitude. Then we put our recording or our reference electrode distally in the proximal thumb, for example, and then we have 2 measurements for median. So median is a good nerve that we can tell you whether, so we stimulate here at this point and record at this, I can give you a measure of velocity through here that is the distal latency. We stimulate again here, so I can tell you the velocity across this segment. I can tell you the amplitude that happens after this gets stimulated, the amplitude that I get when this gets stimulated. So I can give you a lot of information. The only thing is that with the nerves, I cannot give you anything proximally. So I stop at the elbow. We can stimulate, and I have stimulated, we just don't have that much data. We can stimulate a little bit above the elbow here, approximately like 10 centimeters from the elbow stem. There is some data with Erb's point where we start losing statistics of normal values, and we start losing some amplitude, and we start getting close to other nerves, like the ulnar nerve is just like a little bit lower, and you can get co-stimulation. But these are different examples of patients that these are from last week. So this is how a normal median nerve will look like. So we have a nice amplitude here of 11.4. I go more proximally and I get a 10.9. Velocity across this segment, 53. Distal latency, normal, median nerve. Another example of a median nerve. We have normal distal latency, normal velocity, not as big as this one, and it's still normal. This person is just older, and slightly slow conduction velocity. This could be this slightly, and that's where we put the report together. That slow conduction velocity could be from a more proximal median neuropathy that we just cannot document because the elbow is as far as I went. It could be part of an underlying polyneuropathy. It could be part of an underlying brachial plexopathy. So this is just telling me the axons that go through the median nerve, whether it's the whole entire median motor axons at the forearm or at the upper arm, or it's the CAT1 levels, axons that come from CAT1, are those the ones that get affected? Maybe C1, maybe C8 more than T1, or the opposite. Another example, this is a median nerve of a patient with a very advanced CIDP. So you see here, the distal latency is prolonged. So this median motor has the take-up much later, 5.7, but a super low amplitude. Don't be deceived by the fact that this is nicely looking, because for it to look like this, we blow it up. This one just is 5 millivolts per square. This is 1 millivolt per square. So also pay attention to that when we put these pictures are part of the report, but we have to blow it up in order for us to know where to put the markers. And then when I try to simulate proximally, I get no response. Yes, the patient could have a median neuropathy across the forearm, but I know that this is not the case for this guy because every other NEM that I did were abnormal and their exam suggested CIDP. So the to the form. Not as severe as this guy. The distal latency is better. Amplitude it's definitely reduced, less than 4, so it's reduced, but it's twice of what this other person is, 2.3. It does drop to 1.1, so we are getting greater than 50% drop of amplitude across the forearm and a very slow conduction velocity of 26. Anything below 40 for the median nerve is going to be demyelinating. So again, this person could have a focally appearing demyelinating injury across the forearm. And if the person comes and they had some sort of injury at the forearm, that's going to be part of the differential. Or they had acute pain prior to it and it's potentially a parsonage terminal. It could be, but it could also be vasculitis. It could be CIDP. It could be a tumor. So a lot of things can happen and we just have to put everything together. Another big important thing, and I think I have it I'm going to come back to this one because this one is from the motor standpoint. Another important things for you to keep an eye on, and I know that Eric does this and Michael also does, like you look very into a lot of detail the studies, and you should. Like I also see any study that I get that is not my specialty, I try to analyze it as much as I can because I want to make sure that there's no technical factors that kept my study from being the best study they could give you. And this is sometimes things that you guys do. So you get a study, you send someone for, I think they have carpal tunnel, and they get this completely other diagnosis from the electrical study that makes no sense. You guys want to repeat it, but there's multiple things that can make a study go wrong. So just looking at this picture, these are different places where this patient is being, the ulnar nerve response to a Dr. DPG minimi is being recorded. So usually where I would put it is here. And that's approximately one of these two. But see, like if you change the location of your electrode, you may get a smaller response. You may get a positive dip here, and it's hard to tell where the waveform starts, another positive here, another positive on the other end. So you wanna be where the end plate it's thought to be to get the most perfect CMAP of your ulnar nerve. So if you start getting studies and you start seeing waveforms like this, like there's a lot of, sometimes I cannot get rid of the positive. I move that electrode everywhere and the positive dip is there. But if you get studies that everything has that positive dip, everything is multiple phases, the amplitudes appear low in a patient with a normal bulb motor, like motor bulb, and we are giving you a low amplitude, but not that much prolonged distal latency, something is off. So placement of electrodes, extremely important. Errors in measurement, extremely important. As I said, like we have to measure here to here in order for the computer to tell me the velocity. So here, for example, it was 22 centimeters. It gave me 53.1 centimeters. If I miscalculate this and and you guys all know how we calculate velocity. So we have distance over time. If I underestimate the distance or I overestimate the distance, I'm going to change completely the result, and I'm going to give you an abnormally slow or abnormally fast conduction velocity in someone that has the opposite. And another important thing is temperature. we have a lot of patients. It happens with the hands. It happens more with the lower extremities, but it happens to the hands. Patients have cold hands. Patients may just naturally have cold hands. And if you don't warm a patient, you are going to get, and imagine how bad this affects someone like you that you're suspecting carpal tunnel. So if you have a temperature, an abnormal temperature, too cold, less than 32 degrees, you can cause velocities to go slow. You can cause velocities, data latencies to prolong, and you can get amplitudes to appear larger than normal. So someone that you suspect should have axon loss may appear as if they don't because they're too cold, and someone that shouldn't have carpal tunnel or nerve conduction study looks like they have carpal tunnel because the study was done on a cool limb. So very important. We've had a lot of patients that the study doesn't fit. I don't think you should, it doesn't make sense that study is so slow and we are doing the study and the patient is like, no one ever warned me before. I remember I did the study with the whole limb. So very, very important, those technical factors, especially when we're talking about milliseconds that can make a difference on whether someone is deemed to have carpal tunnel or not. Or amplitude, an abnormal amplitude of your lateral antebrachial or medial antebrachial, amplitudes that are so small at baseline that if they're supposed to be at 10 and the person really has a 5 millivolts, but then they're cold and they end up being an 11, I'm going to tell you this person doesn't have an upper trunk plexopathy, that because sometimes the plexopathy is just sensory, and that's just not acceptable. I think you'll find them as useful. You probably rarely see them. We report much about it in the studies that you send us, but late responses are CMAPs. So the same motor action potential that gets recorded to the muscle and the same muscle fiber, but after you send the stimulation the other way, so instead of stimulating at the wrist and recording directly at the APB, for example, what we do is we flip the direction of the stimulation. The stimulation goes antidromically all the way to the motor neurons. Certain motor neurons get activated, and then the response returns and it goes to the same muscle. So it gives you an idea of a more proximal lesion, but the main motor studies that we have F waves on for the upper extreme is just median and ulnar. So unless we're suspecting something CAT1, we don't have F waves for the other nerves that you are interested in. And then we go to the SNAP. So the SNAP is the sensory counterpart of that motor amplitude. So that's the sensory nerve action potential. The way we do it is we record over usually a finger, because most of our sensory studies are in the hand, in the finger where that sensory nerve innervates. So if we're doing a median nerve study, we will usually record over digit 2. If we're doing an ulnar study, over digit 5. If we do a radial study, we actually record over the snuff box. And then, of course, MAC and lag, we do it more proximally in the forearm. You'll see in a bit that there's certain times that I do other fingers for the median sensory study, and that's how we design some of the brachial plexus studies. But in the leg, the main nerve is the sural nerve, and it's there, it's not there, that's it. But it doesn't have that much weight in localization. But in upper extremity, the sensory nerve action potentials are very sensitive at picking up a neuropathy, some sort of axon loss. And I really rely on those sensory nerve action potentials to localize that brachial plexopathy that you referred to us. It also helps us diagnose, and that's another big thing that you often ask us, it also helps us differentiate preganglionic versus postganglionic lesions. So any preganglionic damage of the nerve usually is a radiculopathy, but one big thing that for you it's important is an root avulsion, for example, because it happens before the dorsal root ganglia where the sensory neuron cell is. the actual sensory neuron and its axons are intact. So you could have complete plegia of that limb, plegia of that muscle. And if the problem is at the root, because it was avulsed or because there is a radiculopathy, your sensory nerve action potential is going to be completely normal. So that's very important for you to remember. And that's why we really get very anal about getting as best quality snaps as we can. And this is just example of a nice normal sensory nerve action potential to the median nerve. We're recording over DV2 and we get an amplitude, anything above 20 is normal, an amplitude of 51 with a velocity of greater than 50, beautiful. This is a person with carpal tunnel. The amplitude is 8.5, the velocity is slow, and that person has some sort of damage to the axons of that median nerve that is causing both the amplitude and the velocity to go down. So then, putting all of this together, every time you send us a patient with a potential nerve injury, we get a brief history and exam. It's not that we have a lot. If we get to see the patient in clinic first, then perfect, but you guys know that it's not practical for us to see a patient fully when we could do the nerve conductions before, especially if you already know what the injury is, you just want to know what's the degree and if there's any activation happening, any recovery that has happened, or you want to make sure that there's no other nerves affected, or very frequently you have someone with some sort of rotator cuff problem and there's barely any movement of that shoulder and you want to do some sort of procedure and you just want to make sure that that deltoid is not the risk, that there's no axillary neuropathy that is causing that deltoid to be that weak. And you want us to confirm that there's no axillary neuropathy. So yes, sometimes we just don't need to see these patients, but we get a brief history, we get an exam, and then with that, I design my nerve conduction studies. I usually use my sensory response to have like a general idea of where the problem is. Then I get my motor responses to confirm that there's axon loss versus myelin loss. But you'll see we have very few motor responses that we can work with in the arm. And then EMG to narrow down specifically where the problem is and more precisely tell the degree of the injury and maybe the age of the injury. And you are all very familiar with the brachial plexus. We're not going to go over it, but I just wanted to show you how I plan my nerve conduction studies from the sensory perspective when I'm doing a brachial plexus study. And it'll be very clear why motor studies are not that important unless you're asking for carpal tunnel, ulnar neuropathy, radial neuropathy. Motor studies are beautiful for that. Any other nerve, axillary, suprascapular, musculocutaneous, we just don't have we don't have motor studies for this. So think of the trunk of the nerve that you're thinking that can be affected and what sensory axons go through it, what motor axons go to it, and that's it. That's how I plan it. So the simple ones, my median nerve, ulnar nerve, and radial nerve, I have a median motor and sensory, an ulnar motor and sensory, and a radial motor and sensory. So those are easy. If you think someone has a radial neuropathy, you'll get a radial motor from us, a radial sensory from us, and you'll get median and ulnar as well, because as you guys know, and a radial neuropathy differential diagnosis is the posterior cord, and it's also a root level, or it could be multifocal motor neuropathy, or it could be ALS. So we have other nerves that we have to put as part of the study. But we have a good motor and sensory nerve to localize a radial, a median, and ulnar. And this is where my sensory start coming. So let's say that I think someone has a musculocutaneous neuropathy. We don't have a good motor. Yes, I can get a motor. I put Erb's point, stimulate supraclavicular fossa, record at the biceps, but we don't have normal values. I have to compare it to the other side. And most of it is going to be the EMG. But we have a lateral antebrachial cutaneous. Very easy to get sensory response, and we can document whether there's axon loss at that level. We have also the lateral antebrachial cutaneous. though it's part of the musculocutaneous, it was part of the lateral cord before it became the so sensory is also going to help localize that cord. The median sensory is also going to help me localize at the lateral cord. So if I have someone that has a lateral cord brachial plexopathy, and the differential is an isolated musculocutaneous neuropathy. In the musculocutaneous, my leg is going to be abnormal. In the lateral cord, the left and the median sensory is going to be abnormal. And if you see here, I am saying median any nerve. So I could technically record the median sensory from digit 1, digit 2, digit 3, and if it's lateral cord, all those 3 dermatomes are through that nerve, they should be abnormal. The one that we have the most normal values and the most data is on digit 2. That's why you often see us do digit 2 for median sensory and lateral cord. For the medial cord, we have the medial antebrachial cutaneous. We rarely just have a medial antebrachial cutaneous neuropathy, but we could. And if that's the case, I could put max sensory down here. It's just not a common nerve that we are looking for, and it's a purely sensory nerve. But if we have a medial cord problem, the max sensory will be abnormal and the ulnar sensory will be abnormal. So another big, this is where ulnar starts coming. Then we go to your trunks. We know that the upper trunk is C5 and C6, and the lag sensory, it's more C5 than C6. So I usually do lag. Like I really rely on lag for that upper trunk brachial plexopathy that maybe has more C5 to it. And then the median sensory is also important in the upper trunk, but mostly median sensory to digit 1. So digit 2 has both C6 and C7. So it's, you may see if you send me someone that has a more a brachial plexopathy per se and not a distal mononeuropathy, you see me to just get this gets, and I really try to get as little as I can without compromising my data. So I sacrifice digit 2 and I do digit 1 and digit 3 because digit 1 is a very C6 heavy nerve and it helps me localize to that upper trunk. And these 2 also help me think of, we've all had this, like more preferential fascicular involvement, a plexopathy that is more C5 or C6 or C6 more than C5. C7, very rare you see a middle trunk brachial plexopathy, but we have a good sensory nerve for it. So we have median sensory to digit 3. So that's helpful. So sometimes I get digit 1 and digit 3, and digit 1 is abnormal, digit 3 is normal. That already tells me that it's not a median neuropathy because there's no way a median neuropathy is going to cause sensory to digit 1 to be affected and the 3 not to be affected. So that's where it starts. The fact that the median nerve divides so much is very helpful. The fact that the median nerve divides in upper sensories and lower motors, it's so helpful. And then for the lower trunk, we have the ulnar sensory represent mostly for C8 and the max sensory mostly for T1. So this is how I design my sensory studies. Then of course, my median motor, C81, ulnar motor, C81. I think I forgot the reds for the posterior cord. If I think someone has posterior cord, we don't have nerves for axillary, we just don't. So it's mostly still the radial, motor, and sensory. But a posterior cord, it's going to have, because that's axillary and that is radial, the EMG is going to help significantly when we do a sensory study, when we're doing a localization with the EMG. Then these are the sensory studies that we do. The common motor studies that we do the median, ulnar, radial, which I've repeated multiple times. The ulnar, we can do at the wrist, below the elbow, above the elbow. So we can give you 2 sites where there could be potential focal slowing. So an ulnar neuropathy across the forearm or an ulnar neuropathy across the elbow. Radial nerve is the one that has the most sites. So we can stimulate at the wrist, at the forearm, below the radial groove, above the radial groove. So we can tell you posterior interosseous neuropathy, for example, if there's a drop off between forearm and wrist or below the radial groove and wrist, we can give you a radial neuropathy across the radial groove. And then the other ones that I told you, we can get CMAPs to deltoid, we can get CMAPs to biceps, but very painful. We have to use high stim to get a tiny response that it's hard to interpret when we know that we can just put a needle in those muscles and be done with it. Again, these are studies that are costly and it's not as costly as the surgery that you guys do, but it is a costly study. They are billed in pairs. So every extra nerve that I do above the even number, an extra level of what it costs, and patients often get a bill of like their copay, and it's not a low bill. And what are we looking when we're doing these motor studies? So if we have something that has axon loss, we're going to see the reduced amplitude. We're going to see maybe slow conduction velocity, depending on how many of these fastest conducting fibers were dropped. If we are looking for demyelination, we are going to look at that normal amplitude, but maybe with conduction blocks or significant conduction velocity slowing. And remember, if we have a stimulation below and above, wherever you think the pathology is, we can give you that presence of that conduction block because we think there is neuropraxia. If the area of the lesion, it's not across two segments that we can stimulate, we're not going to give you that. We cannot give you that conduction block. And this takes me to, before we do some cases, this takes me to the different changes that we can expect with our motor studies. And this is just reiterating a little bit on that first slide. So remember, if we have a conduction block and we think that the problem is neuropraxia and there's just focal demyelination or focal ischemia, and this is from another paper, they are more focusing or more like, they were doing this more intraoperatively as well, so they are able to get more data at a shorter time. But they're seeing here, for example, remember, if we have a conduction block, there's no Wallerian degeneration, there's no axon loss, you get that low proximal stimulation, that normal distal stimulation, and after 5 days is the same. And then as the person recovers, the distal remains normal and the proximal, the one that was low or absent, starts going up. If there's axonal disruption, it looks similar in those first days. As axons start getting lost because of Wallerian degeneration, at those 5 to 10 days, that distal stimulation starts going down, that distal stimulation CMAP starts going down, and then if there's recovery, both start increasing. And then that takes us to our EMG, and that's what gives me that final touch for localization. Good thing is that our myotomes distribution in our upper extremity are all over, so I can sample multiple muscles and know whether that deltoid is affected because it's a C5, or because it's an axillary injury, or because it's an upper trunk, and I can know whether the APV is denervated because it is the median nerve, or because it is the lower trunk, or it's the CAT1 Bradix, because I can sample other muscles from the same myotome and different peripheral nerve distribution and tell whether the problem is a peripheral nerve or a myotomal level affected. It can give you the age of the injury. So if you have denervation, sometime must have happened. So approximately, and I think I have that in the next slide, approximately 2 weeks must happen for denervation to occur. Maybe there's no denervation, so then maybe axon loss just didn't happen. Or the injury is old and there's no denervation anymore. When we get neurogenic units, we can tell how long approximately has happened since the injury. As units remodel, they change in morphology, and I'll show you that in a bit. And then the extent of recovery. And this is the degrees, and that's what I'll show you in a bit, whether the muscle even fires versus how much it's been affected in the firing recruitment. And then recovery. You often send those patients to repeat the study. You did a procedure, or you decided to watch and wait. We get another study, and we see whether now there's firing of a muscle that wasn't firing before. And the next one has videos from us, but this is just, let me see if I have the, do you hear the video or not? Probably not. Let me just put share computer sound. Okay, so now you should. So this is how the innervation will sound like. So we're putting the needle in a muscle, and we just let the needle listen. Can you hear it?
Yes, I can hear it.
So I'm going to play it again. That's just that spontaneous depolarization of the muscle membrane in the background. We're getting fibrillations, and that's just the innervation. And this could be, that's our positive sharp waves. This is not normal. The muscle should have completely quiet resting membrane potential. Then we ask the patient to move the muscle, and this is how a normal recruitment will look like and sound like. You can see a lot of motor units firing. They're nice duration. They're not tall. We have normal values for how broad they can be, how many milliseconds, how many millivolts it could be in height, how many phases it can have. And this is how normally it will look like. This is how reduced recruitment will sound like. And this is a moderate to severe reduced recruitment. You see that big, broad, very polyphasic motor unit. If I were to change this, the gain of the screen, the motor unit will be larger than what it shows. And if you see as it fires, it's firing fast, but nothing else is coming to the aid. And it keeps going fast, and nothing else is happening. It's very unstable, changes in morphology, and it's even going faster. Because if you remember, so we have something called the motor unit. The motor unit is the motor neuron, its axon, and all the muscle fibers that motor unit innervates. And when we have to generate strength, when we're going to contract a muscle, we recruit motor units to generate that strength, that muscle movement. And you first recruit one motor unit, and that motor unit gets to a frequency of firing, and we usually say like 5. It has to fire 5 times per second. When that first unit reaches the 5 hertz, a second unit comes. And then when the first unit reaches 10 and the second unit reaches 2, a third one comes. And so on until the patient fully contracts. We rarely do it with full contraction. It's painful and the screen just gets filled. You cannot differentiate anything. But if you have some sort of nerve injury, your units are going to remodel. And I'll show you what I mean by that. Because there. So anytime you have any type of nerve axon injury, you can recover your strength multiple ways. And these are 2 of them, but you recover the strength by the axons, by either regeneration of the axon or collateral sprouting. What you guys see, someone with a gunshot wound or a stretch injury, especially where axonomesis at the higher levels happened, or maybe neuropraxia that you guys went in and approximated and helped things, you are going to mostly see the regeneration. what we see mostly in someone that has diabetic neuropathy, for example, and the neuropathy is getting better, we see collateral sprouting. That's what we see the most. We have someone with B12 deficiency neuropathy, or even carpal tunnel that caused some axon loss, but the nerve wasn't completely disrupted to the level of a high degree axonal misses or neural misses. We are mostly going to see collateral sprouting. And that's that big, broad, polyphasic unit that you saw in that prior video. And the way it works is, so each motor unit, as I said, that motor neuron, the axon, and all the muscle fibers, they're responsible for just they're already responsible for a few muscle fibers, and one muscle fiber got denervated, and that surviving axon, now it's sending collateral to that one, and now it's in charge of more muscles fibers. It's large. But what you've often seen us report in our reports is these nascent units. So when these things start regenerating from that stump, from whatever the axon had to grow, now this motor unit has less fibers that it's in charge of because it hasn't regenerated to all of them. We get these tiny, small, polyphasic motor units. And these are videos from my phone, so the second one looks awful, but I wanted to show you the difference. This is a neurogenic unit from collateral sprouting. And this is how a motor unit will look like from regeneration. You see how tiny it is. It's the same screen. So those are those ones that I said that are the nascent motor units. And this is just reiteration from what I said. After an injury, approximately 2 weeks, you start seeing the denervation. Reduced recruitment happens immediately because you have weakness. Denervation may persist up to 2 years, but as time goes by, denervation starts disappearing, and you're mostly just going to see that neurogenic changes of the motor units that can be that big, broad polyphasic if we're just having collateral sprouting, or that tiny nascent motor unit because we're having axon regeneration. And you guys know this, so I'm not going to go too much into this. Every time you have an injury, multiple things have to happen for you to have recovery of the movement, in this case, the strength, in this case, sensory. You felt first, if there's any conduction block, that resolves, and that's what gives you that early, quick recovery. Then you start having some distal axons sprouting. That is that collateral sprouting. You get some muscle hypertrophy. Patients start doing physical therapy, and muscle that it's continuous, that has remained innervated, gets larger, and then you have the axonal regeneration. That's what happens at the end. So I'm going to go through a few cases, and they should go fast. They're all cases. I purposely only picked patients that you guys sent. So it's 37-year-old woman with left arm weakness after neck dissection 2 weeks prior. On exam, 0 deltoids, 0 biceps, maybe supra and infraspinatus, 1 or 2 out of 5, sensory loss over shoulder and thumb. So just hearing that, I already suspect a brachial plexopathy, upper trunk plexopathy. And this is someone that they're freaking out, like, what is it? Like, and they are coming to the lab and we're like, 2 weeks, is this too early? Maybe it isn't. What could be useful this early? So if I don't see denervation, that means nothing, because maybe I haven't done it soon enough to get denervation. But, and if there's no motor units, also not useful, because we may be still seeing conduction block, and that's why the person cannot. But if I see any motor units, I know that some continuity must be there. So then you see, this is the study I provide to you. We got a normal median, normal ulnar motor, normal median sensory, normal ulnar sensory, normal radial sensory, normal median to digit 1 sensory. That's that upper trunk 2. The lateral antebrachial cutaneous is just borderline low. Normal is 10. So 9.5, maybe we pass it. But then you see the EMG. It's too early to see any denervation, so it doesn't mean anything. Deltoid and biceps, no activity, but I'm getting a single unit in brachioradialis, a single unit in supraspinatus, a single unit in infraspinatus, with, again, still too early to see large units, long duration units. So we call it as an acute brachial plexopathy. with axonal continuity to supra and infraspinatus and brachioradialis, but a repeat study is needed to assess the degree of axon loss because there's just not enough time that has passed. But at least we are able to tell the surgeon there is some continuity to certain muscles that are clinically weak. Next study, 86-year-old woman with 1 year of left arm weakness after a dislocation. Focus examination shows 0 out of 5 throughout the arm with TRAPS and STM normal. We do nerve conduction study, nothing. No median, no ulnar, no ulnar, no median, not a single sensory. That already tells me we're likely dealing with a panbrachial plexopathy. We go to the needle EMG and it's bad. Everything is denervated and we get absolutely no activity. And I think you guys ordered trapezius. We knew that it was normal, but it was more for surgical planning. So there's electrodiagnostic evidence for a panbrachial plexopathy without axonal continuity to any of the muscle tested. Case 3, we have a 35-year-old man, ATV accident 2 months prior, then had an ACDF, I think a month after. I forgot to change the date here. I was changing everything to 2 months prior, 1 month prior. So 2 months prior an ATV, 1 month prior ACDF, and still residual right upper extremity. And we're getting a lot of weakness. We're getting deltoid 2 out of 5, biceps 2 out of 5, triceps 1 out of 5, EDC low, EIP, finger flexors. So we're getting a lot of abnormalities here in muscles that are upper trunk C5, C6, middle C6, C7, EIP, C81, APB, C81. So multiple levels can be affected. It appears that they also have a reduced lag distribution sensory loss axillary. So maybe panbrachial, but maybe more upper trunk than the rest. Let's see. Median nerve, normal. Normal electrically, we don't know. We'll see the EMG later, but median nerve, normal. Ulnar, abnormal. Normal distal latency, normal velocity, but the amplitude is low. The amplitude for the ulnar is supposed to be 5 or above. Radial EIP, that one is bad. Normal amplitude is 2 or above, we're getting a 0.8. So we're getting the motor fibers to lower trunk or ulnar and radial nerves affected. And then we did the sensories. Median sensory, normal. Median sensory to digit 3, slightly low. Normal is 20, so a little bit low. Ulnar, normal. Radial, normal. We get the LAC, low, MAC, low. So post-ganglionic, at least we have confirmed that upper trunk or lateral cord, because the LAC is down, but that's about it. We have maybe digit 3, slightly reduced. That will be post-ganglionic C7, but that's it. So whatever is going on with this ulnar and this radial has to be preganglionic. Remember that the guy also had radiculopathy, and he had some sort of like cervical spine surgery. Then we did the EMG. We're getting, and this one is 2 months prior. So we should see this study is a good time. We should see what we need to see. We have denervation in practically every muscle that we did. Deltoid, biceps, triceps, pronator teres, EDC, FDI, APB, even rhomboid. We get no activity to those proximal muscles, so that's very important for this guy. Deltoid, biceps, triceps, pronator, EDC, no activity. So all the C5, C6, and C7 muscles, no axonal continuity. Where we get axonal continuity is in our lower trunk muscle, C81. We are getting some, see, here is what we report as that low amplitude, low duration, that's at nascent units to the supraspinatus. And then just some neurogenic changes to rhomboids that give us that proximal root assessment. So what we said is, this is one of the lengthy ones. There's evidence for a patchy upper right extremity brachial plexopathy. There appears to be preferential involvement of patient muscles innervated by the right musculocutaneous, the radial, and the axillary nerve, with less involvement of the CAT1 muscles. But there's also evidence of a preganglionic involvement that could be a radiculopathy at all levels, given the less involvement of the sensory nerve versus the motor nerve. Remember, when we have a good sensory response, we think about something proximal to that dorsal root ganglion. But we call it as this argues against complete root avulsions because we are getting some axonal continuity to C5, C6 muscles. We are getting axonal continuity to supraspinatus, to rhomboids, and to CAT1 muscles. If we're talking about an avulsion, we should have a much more, and these are the ones that have even slightly reduced recruitment. So we should have much more motor changes. But see, like not that much time has passed, just 2 months. So we're only getting broad duration motor units. We're not getting that many tall motor units yet. I have 2 more cases, but I think I'm out of time, Eric, so I don't know if I should talk.
Keep going.
Keep going. Okay. Okay. I cannot see your faces, so I don't know how many of you are falling asleep. 4th case. We have a man, 69-year-old man with a right wrist drop. I think this is Nikki. Right wrist drop after a motor vehicle accident. He had an injury someplace here in the right upper arm. And we are doing the study 3 months after the onset of the weakness. Motor focus exam shows wrist extensor and finger extensor weakness, so a complete wrist drop and finger drop, but preserved FDI, weak thumb abduction. And the question for us is this a radial neuropathy? So you are still going to get from us median and ulnar with any radial neuropathy. And just looking at the sensories first, I already know that this is not going to be a straightforward study. As expected, no response for sensory. That's expected, but I have a low ulnar and a low median. So there's more than just that radial neuropathy. So low amplitude median, low amplitude sensory, and absent radial. But I already know from the sensory standpoint that the radial is the worst one. Then I go to the motors. Normal median motor, ulnar motor with normal amplitudes, normal distal velocity. We rarely see any ulnar neuropathies across the wrist in the lab, but then focal slowing across the elbow. We confirmed this with another ulnar study now to FDI. Same, normal latency. This latency is longer than that one normally. Normal amplitude, focal slowing across the elbow, and a radial, no response. So unfortunately, we cannot tell with the nerve conduction study part, what part of the nerve, where the lesion may be. Because we already distally go no response, so we're not going to get anything proximal. We did a comparative study of the median studies because we needed to confirm the median neuropathy at the wrist. So we have confirmation of the ulnar neuropathy across the elbow because we have 2 studies that show slowing, 1 sensory that shows reduced amplitude, but for the median, we only had that isolated median sensory abnormality. So we had to do a comparative study and we demonstrated slowed conduction velocity across the wrist for the median. So we have a median neuropathy, a mild median neuropathy, mild ulnar neuropathy, and then a radial neuropathy. Then now we have to localize. So because radial neuropathy, also posterior cord, also CAT1, depending on what part of the radial nerve we're talking about, we also have brachioradialis, C5, C6, so the radial nerve is also like all over the place. You're going to see us sample all of that. And the radial nerve is the other, like the median nerve, that because it's all over, it's C5, C6, C8, C1, it's a very good nerve to take advantage of when we're doing the study. So we did deltoid, normal. Triceps, normal. Biceps, normal. Pronator teres, normal. So now we know that the problem that we're seeing, it's not from a posterior cord because the axillary is normal. There's not like a multi-level brachial plexus problem because the triceps is fine and the pronator teres, 2 other C7 muscles are fine. And then we get to, and then of course we have to do FDI and APV to check them off that it's not a CAT1 process, normal. And then we get to our radial nerves, muscles, brachioradiality, denervated no activity, EDC, denervated no activity, EIP, denervated no activity. So that's bad. We again could not localize it, but at least I tell you where it is, and we know where his injury was. So this is an abnormal study. There's electrodiagnostic evidence for a radial neuropathy, and the best we can give you is at or above the takeoff to the brachioradialis, because that's the most proximal muscle we could find an abnormality, and because the triceps was normal. So at or above the takeoff to the brachioradialis, because the brachioradialis, it's similar to the level of the EDC. We also put the EDC there, and the extensor indices goes proximally to the some of the muscles. And then I say there's also electrodiagnostic evidence for a mild ulnar neuropathy at the elbow and a mild median neuropathy across the wrist. And this is the last study. 58-year-old man with left shoulder weakness after shoulder dislocation 8 months prior. So again, enough time for us to give you good assessment of what's happened. Focus examinations showed deltoid weakness, but preserved supraspinatus strength, and EMG was requested to evaluate for an axillary neuropathy. So we first get our nerve conduction studies. We look at our sensories. These already catches our eye. There's an abnormal median, but we know carpal tunnel happens. So maybe that's carpal tunnel. Ulnar is normal. Radial is normal. And the other one that I'm very interested in looking is the lateral antebrachial cutaneous, because I'm getting already a sensory abnormal median. And I said, okay, maybe then it's upper trunk, because median digit 2, there's some C6 in it. But I get a lateral antebrachial cutaneous that is normal. So I'm like, okay, it doesn't appear that it's going to be a plexus issue, maybe just an axillary issue. We'll check when we do the EMG. We do our motor studies. Ulnar is fine. Median, normal velocity, normal amplitude, prolonged distal latency. Okay, so then that and that goes together. He has carpal tunnel. That's not here. That's not what he's here for. But we have diagnosed carpal tunnel in this guy as well. And then we do the EMG. We get, in this case, we were asked specifically to look at deltoid, the 3 heads. So we checked deltoid, middle, anterior, and posterior head. The 3 of them were denervated, and the 3 of them were showing signs of nascent motor units. So you see here, the recruitment is reduced, but we have low amplitude, low duration, polyphasic motor units. Those tiny motor units I showed you in that video, this tells me this muscle is undergoing reinnervation from axon regeneration, not necessarily from collateral sprouting, because we are assuming that the injury was complete or near complete when it happened. And then we get the others just to confirm: FDI, EDC, triceps, biceps, pectoralis, supraspinatus, trapezius, all normal. So this is a pure chronic and ongoing left axillary neuropathy with evidence of early axonal regeneration. Also a mild median neuropathy across the wrist, but no brachial plexopathy. And that was the last one. So anyone has any questions?
That was fantastic. Thank you very much. I'll open it up. Does anybody have questions before
I have not necessarily a technical one, but more of an opinion one.
Mm-hmm.
One thing that I've noticed, and I don't know if it's utility or a resource thing, I find in our unit we're tending to use both EMG and ultrasound to diagnose kind of the simple peripheral neuropathies. Are there any neuropathies you think that suit themselves very well to that simpler study? Because obviously, and you've pointed this out a couple times already, in Dr. Wagner's clinic, sometimes you're like, I don't really understand what the problem is, and EMG is invaluable in that case. But then I also see kind of the utility of a straightforward carpal tunnel syndrome to kind of do a spot ultrasound in that.
And I do ultrasound, so I can do ultrasounds of median nerve and diagnose carpal tunnel or a median neuropathy more proximally, ulnar neuropathy at the wrist, at the elbow. So I do it. I do favor the EMG. If I have to pick between EMG and ultrasound, I'm always going to pick the EMG, but I love doing ultrasound. I do ultrasound all the time for my CIDP. So all those studies that I were telling you that sometimes I get demyelinating velocities across the forearm. These nerves look huge on ultrasound. So I do an ultrasound across the median nerve across the forearm or across the upper arm, and I get these median nerves or ulnar nerves that are 2 or 3 times their size. So I don't need to be sold on ultrasound. If I could do ultrasounds on all of my patients, I would. I think ultrasound carpal tunnel is going to be, if not equally sensitive, maybe a slightly lower than nerve conduction study. So I don't think it's going to miss that many. And I do think it has the added utility of finding non-typical carpal tunnel pathology. So we've all heard the cases of the person that appears to have carpal tunnel and they actually have a tumor, a perineuroma or something across the wrist. Same thing with someone that appears to have an ulnar neuropathy at the elbow and actually it's a tumor, or it's some sort of other disease that it's not necessarily compressive neuropathy. I think for the ulnar neuropathy, I do think that an ultrasound may pick up the ulnar neuropathies earlier than the nerve conduction study, especially if there's not too much axon loss and most of the symptoms are sensory, because your nerve conduction studies may only show reduced sensory amplitude of your ulnar nerve, no slowing across the elbow, EMG normal because the person is not weak, and ultrasound can beautifully pick the ulnar neuropathy across the elbow, and I really do it as much as I can.
Thank you. No, and I think EMG is going to be the gold standard forever, but it's one of those things where you're kind of seeing this new emerging technique and just trying to figure out where it fits. And
I do it, and I have my own, I always get complaints from my bosses that I don't use it enough. I need to find a way to do it more. When I was trained, I found an EMG and a carpal tunnel and EMG, they got an ultrasound. I found an arm neuropathy, got an ultrasound. If I could do an ultrasound of every patient, I would do it.
That's awesome.
So Spencer,
your bosses encourage you to do ultrasound. I wish my bosses would buy us an ultrasound.
No, it's just that they bought me the machine and I don't use it as much because I don't have time.
I have the opposite problem, Carolina. My boss, who's right of me on my screen, won't buy me an ultrasound.
But it's like $60,000. That's like for you, like one suture.
I agree, Gottschalk. Are you listening?
Well, so I think if you notice what happened, she just said they bought the machine and they didn't use it enough to actually pay for the machine. So that's part of it too.
Yes, but the thing is that no, and I'm training my fellows to do it. Vita was supposed to learn. She just like other stuff happened. The thing is that, and this is what my mentors told me, you don't need to pay the machine back because the machine is just an extra thing you do to do more studies, to get more patients. So if a patient can come to see me for the EMG and the ultrasound versus someone to do the ultrasound on one side and the EMG, I'll probably get the EMG and not that other place.
Yeah. So one thing, Spencer, I want to make sure that you, all joking aside, Spencer, I want to make sure that you took in what she said. That the gold standard is different based off of the pathology of the nerve that you're studying, right? And so when you have an EMG or nerve conduction study that's very good, like for carpal tunnel, ultrasound may never surpass that because you've got something that's highly sensitive and specific. Whereas when you look at something like the ulnar nerve at the elbow, the electrodiagnostic testing is actually not nearly as good. And so ultrasound likely will pick it up earlier. And that's exactly what we're studying, where we're looking at this nerve registry now. We're looking at all the patients that had ultrasound and we're looking at all the patients that had electrodiagnostic testing and vice versa. And you're seeing all these negative electrodiagnostic tests, but now potentially positive ultrasounds, right? Yep. And that's because you're catching it much earlier than you would typically. It hasn't caught up because you don't have later stages. And you see that clinically, and you see that the patients respond to that surgically as well. So anyway, I just want
that also could be. That also could be. I mean, that there's a dynamic process to cubital tunnel. with the elbow flexion.
Yes,
I think there's a lot to understand about cubital tunnel.
And it's not like that more like chronic compression as that it happens in the carpal tunnel. The pathophys is different. It's just different. And the thing is that the good thing about the ultrasound is I don't do too much the spot ultrasound. When I do an ultrasound of a limb, it's like the EMG. You send a patient for carpal tunnel, you're getting an ulnar study with it. That's it. When I do an ultrasound of an arm, I see the median, the ulnar, and the radial nerve. I see everything. So if I'm doing someone carpal tunnel, I may find an ulnar neuropathy, and it's just because the test, it's for me, it's like it pays the same when I do that, and I just got more information. And the other is, what if you have a patient with typical carpal tunnel and they actually have something else causing the problem, and maybe something more proximal to the median nerve that wouldn't, with the carpal tunnel, that wouldn't be the typical compression. I just feel like every time I get to do an ultrasound, I also have that relief that, okay, I'm not missing an additional pathology, because you could have a median neuropathy across the wrist and you may miss a more proximal median neuropathy that that patient may have. And sometimes I just image the nerve and I just know, okay, I know that you don't have multiple nerve enlargements throughout your upper extremity. I'm not missing something else. It's just carpal tunnel. It's just ulnar neuropathy.
No, and that's excellent. My question is mostly how they complement each other, and just to be frank, sometimes access where I'll be working isn't great to EMG. So if you meet 10 people in a day, and obviously, and I know Dr. Gottschalk will comment on this, you can make the diagnosis clinically, but it does make you feel nice to have some objective measure. And
carpal tunnel syndrome it's supposed to be a clinical diagnosis. So yes, you diagnose it clinically, and then you have an objective evidence that you have it. And if you don't have any major weakness and it's just mild, a little bit of sensory loss, you're probably not even going to consider surgery yet. You're going to do some conservative management.
Yes.
So Carolina, let me ask you this. You can answer this now, but I'm also going to ask you, would you be, if we sent you a cubital tunnel questionnaire that goes through a bunch of case questions, would you be willing to respond and say which ones you think have it and don't have it based off of their clinical findings?
Yes.
So one of the questions that I'm studying now is, right, we say it's a clinical diagnosis. Mm-hmm. Which clinical examination maneuvers do you have to have in order to be considered to have cubital tunnel? Mm-hmm. Do you have a strong sense or feeling of which ones you have to have? Like, is it a positive Tinel's? Is it a positive elbow flexion compression test? Is it positive stretch collapse?
You'll never see a neurologist do stretch collapse. I don't even know what you're talking about. I have no idea.
Wait, you said you never do what?
I don't even know what a stretch collapse is. I would
never see a neurologist do a stretch collapse.
Personally, I think it's garbage. But yes, keep going.
There's like one that you rub alcohol or stuff. I also read some weird stuff about like peroneal nerves and stuff. But I do Tinel's. And that's it. The rest of it is my exam. I check your FDI, your ADM, your FCU, your FDP 3 and 4. I do sensory of your, and then I get the whole history, and you have the typical picture of a ulnar neuropathy. That's how I do it. So I do Tinel's.
Now, do you do Sims-Weinstein and 2-point or no?
What? I have no idea what you're talking about.
So do you use the Sims-Weinstein monofilaments, like monofilament testing? No. Interesting.
We just
what about 2-point discrimination?
You almost never see a neurologist do any of those stuff.
Maybe one of these times we should show you. It's an adjunctive stuff. So I mean, you know what Sims-Weinstein for diabetes, where you test stuff.
But we don't ever do it for diabetes.
We use it in the hand as well.
Yeah, but we don't even use it for diabetes either. We use our tuning fork. We use our temperature. We use pins. We don't use monofilaments.
Interesting.
A lot of neurologists in the community will, and we just don't. And I've trained in a bunch of places. No one ever has a monofilament. But I think it's a good way for someone, like, for example, if we have an orthopedic doc or a podiatrist that is like you're not going crazy with your reflexes. You're not putting a tuning fork in each bony prominence for X amount of seconds and document you did like 7 out of 8 seconds here and like 8 out of 8. You're not doing all of that, but we are. So we don't need that monofilament because we're doing temperature, we're doing pinprick test, and then we are getting the reflexes and the strength. So we rarely do those other things that other specialties may do.
Interesting.
Yeah, but send me the questionnaire. I don't want to mess up your data though, because
I think it'd be interesting just to see. You know, it's an interesting thing, because as I tell everybody, the diagnosis of cubital tunnel, Wagner made fun of me because I'd be like, hey, they've got a positive Tinel's at the elbow. That essentially to mean that you've got something going on with your nerve, almost always.
When
But like,
you
for
take
example,
a reflex hammer to the
so
elbow,
for example, and I can tell you,
when you take a reflex hammer to the elbow and you start hitting it enough times, the reflex hammer you use for like the patellar tendon.
Mhm.
When you take that to the elbow and start tapping people's elbows,
you'll get a Tinel's. I think you'll get a Tinel's. And the thing is that, so for example, I've done ultrasounds on me. My ulnar nerve is perfect. I've done nerve conduction study. My ulnar nerve is perfect. But if I'm doing overweight, I'm always getting subluxation of my nerves, and I have a Tinel, and I can reproduce it every single day. But I know that
you have a snapping triceps.
I have a no. My
Your
ulnar nerve
Did your triceps?
Yeah. No, my tricep doesn't. Mm-mm. And I looked at it because when I was studying, I will look at it, and maybe I have some minor nerve irritation that is giving me that Tinel's. But I've done multiple nerve conduction studies on me, and I've done ultrasounds, and I have no symptoms of ulnar neuropathy.
No, I think that's where Eric was saying sometimes these things are dynamic, right? So if you do something repetitively over a period of time, you may get actually small symptoms, but
exactly, and then the result.
Yeah, but I think that's why I was saying, it's interesting because we always say it's a clinical examination maneuver, but the question is how many of these things have to be positive for you to say, hey, yes, someone's got it.
Exactly, and does it fit the patient's history? So if they have like vague pain here and there, like the whole arm goes dead,
correct, yeah, their whole arm's numb, correct, yeah. I mean, I think that's one of the things we're trying to answer now with this next phase. So we put together a list of a whole bunch of stuff. I can send it to you later, but it's coming. I can send you the article we just published, and there's another one coming out. Hopefully once we get this part done, but it's interesting stuff. So,
any other questions anybody has?
All right.
All right. Well, we've kept you way too long. Thank you very much. You were awesome.
Sorry.
No, that was amazing.
This is great.
Thank you
as always, Carolina. Thank you so much.
No, that was amazing. Thank you.
Thank you.
Thank you.